So, good evening, everyone. I welcome you all for this fantastic Friday webinar on early FGR. Early FGR and preeclampsia are the two major contributory factors for increased perinatal and maternal mortality in India as well as worldwide. And under Samrakshan program, we are focused to tackle this problem to make aware people about the gravity of these two problems and to reduce the number of patients suffering from them. Early FGR, if diagnosed early and followed properly with fetal Doppler, can result in better outcome. So today, to discuss this important topic, we have with us our chief guest, Professor Dr. Shibani Mehra, who is the president of Delhi chapter of IRIA. Ma'am is the professor of radiodiagnosis in Dr. Ram Manohar Lohia Hospital in Delhi, and she is the past vice president also of the Delhi chapter of IRI, Secretary General International Medical Sciences Academy, and she have various publications to her credit, more than 65, and she's presented lectures and presentation at various national and international conferences, and her academic interests are cardiac radiology, musculoskeletal radiology, and neuroradiology. Our other chief guests are Professor Dr. Praveen, who is the Secretary IRI Karnataka State Chapter of IRI, who is, I think, is not able to join up till now, but we'll see if he can join. We'll talk to him. Till then, today's speaker is Dr. Kavita Aneja, who is a senior consultant and radiologist in New Delhi. First of all, I request Dr. Shibani, ma'am, please, if you can say a few words about Samrakshan and our this webinar series which we are promoting for preeclampsia and FGR.
Yeah, thank you so much, Dr. Sandhya, for that nice introduction. And I'm so proud and privileged to be part of this Samrakshan program that has been initiated. So we are into the 21st century, and yet we are struggling with a major issue in India, and that is the alarming level of perinatal mortality rates in India. If we take the statistics from the largest state, that is Uttar Pradesh, as per the National Family Health Survey, about 56 per thousand pregnancies is the perinatal mortality rate. And this is a major amount. It's not a small number at all. We know that the major chunk of perinatal mortality is contributed by prematurity and Iugr. So Samrakshan, of course, is a wonderful concept of IRIA, which was initiated recently in July 2019, if I am correct, which aims at preventive radiology and training in fetal radiology. Now, we all are aware that there are various levels of health infrastructure in a vast country like India. We have the top level care and hospitals as well as diagnostic centers that are very ably equipped in the metropolitan cities like Delhi, Mumbai, Kolkata, and Chennai. And then we have the primary health centers at district levels, which are not that well equipped to deal with any antenatal or neonatal emergency. Now, this disparity is because of two reasons. The fact that most suitably trained doctors, be they radiologists, be they neonatologists, want to work in bigger cities, maybe for the quality of life, also for the kind of opportunities that can be found in these cities. And also because of the lack of awareness regarding the menace of antenatal complications amongst both the doctors and the patients. There is definitely a lack of awareness. And whatever the case, the casualty of this haphazard distribution of healthcare is the hapless patient who needs continuous and very careful monitoring all through pregnancy for any untoward event that can occur at any stage. A lot has been done in India, of course, over the past 3 decades since 1990 to bring down the maternal mortality rate. Indeed, it has fallen significantly, and this is because of all the policies of the government of India, to place emergency obstetric care services in all the health centers, providing ASHA workers, Anganwadi workers to motivate the women in rural India to register for proper antenatal monitoring and follow up, and of course, subsidizing cesarean sections at most of the hospitals. But one must realize that with the most effective screening tools, you cannot predict which woman will develop pregnancy related complications and at what time these complications can develop. So it is very important to recognize that every pregnancy is special. Every pregnant woman must receive special care all through the pregnancies. The complications are quite unpredictable. They can happen. Hypertension, diabetes can develop during pregnancy. These are the ones that are acquired during pregnancy, and then there can be pre-existing complications, like the patient may be suffering from epilepsy, some renal disease in the background, tuberculosis, sexually transmitted diseases, all of which can adversely affect the antenatal outcome, especially the growth of the fetus. And fetal growth has to be monitored extremely carefully. We know that any baby with IUGR needs special attention all through the antenatal period as well as perinatal and postnatal period. So we as radiologists have a lot of responsibility on our shoulders. We need to be able to identify all cases of IUGR at the earliest due to our expertise in fetal ultrasound imaging. Similarly, as you were saying yesterday, I was listening to your talk, Dr. Sandhya, it is essential that Doppler imaging should be a part and parcel of each antenatal workup, because the uterine artery, umbilical artery, ductus venosus waveforms, they are the first indicators of any impending danger to the fetus, and they give us a direct window into the feto-maternal circulation. So training of each radiologist in preventive medicine is the need of the hour. Samrakshan is a wonderful initiative in this direction. It is indeed very well conceived. All of us who are teachers in the medical institutions and those who are leading the radiology associations at various levels must ensure that each and every radiologist grasps the significance of fetal antenatal monitoring through Doppler and ultrasound, so that a timely diagnosis of any antenatal complications, growth retardation, can be made and interventions can be suitably instituted. So, in my capacity as president of Delhi chapter of IRIA, it is going to be my endeavor to conduct workshops focused on preventive fetal sonography, going through this pre-eclampsia week discussions has been an eye opener. And I intend to be involved in the Samrakshan program, A, by increasing the awareness about it at our unit territory level amongst the radiologists and also the obstetrician colleagues. Also by holding, as I said, fetal imaging workshops and sensitizing all the students coming to us in this regard, that how acute the problem is and how we must all contribute. So I'm glad that Dr. Riju chose me to be the torchbearer of Samrakshan program in Delhi, and I wish all the success for such a noble cause to everyone who is involved with it. This is truly the best way to do our duty as a service to mankind and our fellow human beings. And I hope that I can be suitably involved with whatever responsibility is given to me.
Thank you
Thank
so
you.
much, ma'am, for so much of kind words. I'm grateful to you for helping Samrakshan to reach out to so many people in North India. I hope, like you being on such a post, it will be, it can go to masses if you lead us in that region. And um, I think without wasting now more time, should we start, Dr. Lalit?
Yes,
Yeah.
yes, yes.
So we have today's speaker, uh, Dr. Kavita Aneja, and she is the past executive member of IUFMB faculty in various regional and national conferences, and she has been awards in different conferences, including the International Conference of Radiology in ACOR 2017, again in 19 IRI Chandigarh, and then in USCON also she's got annual national conference of ultrasound, and she has many reviewed publications in journals of national repute, and she has a sign to her name, K angle sign, for early diagnosis of bladder exstrophy which was pioneered and published in IJR December 2017. So over to you, Dr. Kavita, and we are looking forward that you will solve all our dilemmas about the early onset fetal growth restriction.
Thank you, Sandhya, for very kind words. Is my screen visible?
Yes,
Yes,
yes.
yes, visible.
Okay. Good evening, everyone. At the outset, I really want to thank IRIA and Samrakshan for this opportunity. It's indeed a pleasure to be speaking on this forum. Fetal growth restriction has been very widely spoken about, yet it is confusing when put to clinical practice. And why we need to know about the growth lag is because we want to deliver neurologically healthy babies and not just live babies. Much of my talk is influenced by my teachers, Dr. Bijoy, Dr. Vimal Sani, Dr. Bavaharan. I'm really grateful to them for their teaching. A few words about Samrakshan. Samrakshan is a national program of IRIA which is doing some exemplary work in reducing perinatal mortality, low birth weight, and preterm babies in India. This project was conceived and founded by Dr. Riju Matthew, and I'm fortunate to be a part of Samrakshan for a while now. So that is the outline of my talk. So we'll begin with why is growth lag important? How do we identify small fetuses? How do we differentiate fetal growth restriction from small for gestational age babies? What is early onset and late onset IUGR? The definition by Delphi consensus, tools for surveillance, which are growth charts and Dopplers, the stages of FGR and stage-based management by Barcelona Protocol by Kratakos. Do we need to address this issue? Well, 26 to 30% of pregnancies in India have small fetuses. That means every third mother coming to you will be carrying a small fetus. These fetuses are 4 to 8 times at higher risk of perinatal mortality. They are at high risk of preeclampsia. 50% of these babies have short-term morbidity like fetal asphyxia, hypoglycemia, hypothermia, polycythemia. And then there are long-term morbidity in these babies in the form of increased risk of non-communicable diseases in adulthood, which are diabetes, hypertension, obesity, and cardiac diseases. These babies have an increased incidence of neurodevelopmental delays and GI problems after birth. As much as we talk of aneuploidies, the major chunk of adverse pregnancy outcome lies here, which is FGR. How do we identify a small fetus? Step 1 is to establish the gestational age of the fetus. Step 2 is estimate the fetal weight and then calculate the weight percentile. Assigning gestational age has been very elaborately covered by my co-speakers in previous sessions. LMP is very dicey because 50 to 60% women will not know their LMP correctly. In the first trimester, CRL is used for dating, and in second trimester, it is compound measurement by BPDH, CFL, and AC. And when the discrepancy between ultrasound dating and LMP dating is more than the variation expected, we support redating of the pregnancy. So I'll just touch upon this. This has already been taken up. So before 14 weeks, before 9 weeks, we do it by CRL. And if the discrepancy is more than 5 days, we redate the pregnancy. Between 9 and 14 weeks, again, dating is done by CRL. And if the discrepancy is more than 7 days, we redate the pregnancy. 14 to 16 weeks, dating is done by composite measurement. And if the discrepancy is more than 7 days, we redate. Between 16 and 22 weeks, a difference of more than 10 days, and between 22 to 28 weeks, a discrepancy of more than 14 days, we need to redate the pregnancy. Beyond 28 weeks, we really don't like to redate. These pregnancies are termed as inadequately dated, but if the patient comes to you for the first time in the third trimester, we need to do 2 scans, 2 to 3 weeks apart, and then assign the EDD. And why is dating important? Because now we talk in terms of centiles. And centile is gestational age dependent. So if the umbilical artery has a PI value of 0.9, it has a different centiles at different gestational age. And so if the gestational age is wrong, if the dating is not done correctly, the centiles will be wrong and our assessment of FGRs will go haywire. Similarly, for the biometry, we need to know the centiles for which gestational age is extremely important. So make the mother aware about the difference and the redating if it happens. And once assigned, do not change the EDD in subsequent reports. We all know this. Estimating the fetal weight. Weight can be estimated from one of the many published formulae, which include fetal head, abdomen, and femur. Find the percentiles of the biometry and the weight and plot them on growth graphs. So what is a small fetus? Small for gestational age fetus is the one which has weight less than 10th centile for gestational age. And I repeat, it is less than 10th centile for the gestational age which has been assigned to the mother by the dating scan. And it is not the 10th centile of the ultrasound age because ultrasound age could vary a little in every scan. Hence, a correct gestational age is the most important factor to ascertain. And what are centiles? If a 30-week fetus is in the 40th centile for weight, that means 40% of 30-week fetuses weigh the same or less than this baby, and 60% will weigh more. Now, regarding the charts, there is a lot of discrepancy. We have many published growth charts. So we should be following a chart which is a standard chart like intergrowth, WHO, and headlock. Headlock 3 is a universally accepted growth chart because the trajectory is comparable in observational studies across the globe. So small for gestational age baby is the one which has weight below the 10th centile, and the babies below the 10th centile, 70% of them will be small for gestational age babies, which have normal fetal-placental function and normal Dopplers, and no additional risk of perinatal morbidity and mortality. Most of these are true or constitutionally small fetuses. The remaining 30% of babies with weight less than 10 centile are the growth restricted babies. Well, this 30% number is on an increase now because we are seeing more and more of FGRs in practice. So out of 30% of FGRs, 20% will be because of uteroplacental insufficiency and 10% because of chromosomal abnormalities or structural abnormalities or infections in the fetus. Now, what is FGR? A fetus with an estimated fetal weight of less than 10 centile on ultrasound that, because of a pathologic process, has not attained its biologically determined growth potential. So it is a fetus which has weight less than 10 centile and which has a pathological process going on, which is in the placenta, and which is not able to attain its genetically determined growth potential. Now, how do we know what is the genetic growth potential of a baby? So, since failure to attain growth potential is a concept difficult to gauge, fetal size is used as a proxy with all its limitations. And this is to say that the growth potential could be different for different people, and the size could be small, but growth potential could have been achieved. So size and growth potential are not the same. Size is a proxy for growth potential. So fetal growth restriction is not about size. It is a functional problem of unmet fetal need because of some pathology in the placenta, which is not able to meet the increased demand of the baby. Fetus is unable to reach the genetic potential because of unfavorable environmental conditions, which are nutrition and oxygenation from placenta. So what are the fundamental differences between FGR and SGA? SGA, or physiological smallness, is weight less than 10 centile. FGR is pathological smallness, and the weight or AC less than third centile is an absolute, it takes the baby to FGR. We can call the baby as FGR if we have weight or AC less than third centile as solitary criteria. If the weight is between 3 and 10 centile and the Dopplers are abnormal, this baby is FGR. So SGA is essentially between 3 and 10 centile, because less than 3 centile, we'll call it FGRs. So SGA with abnormal Dopplers is what is FGR. So are all SGAs FGR? And the answer is no, because SGAs will not have Doppler abnormalities. Are all FGR SGAs? And the answer is still no, because there is this group of AGA babies which are appropriate for gestational age, which with abnormal Dopplers, they qualify to be called as FGRs. And these are the babies between 10th and 50th centile. So if we look at this bar graph, this is the perinatal mortality. And the babies less than 3 centile have a very high perinatal mortality, understandably so. And babies at 10 centile also have a high perinatal mortality, but this is a 50th centile. There is this group between 10th and 50th centile, which also has a substantially high perinatal mortality. And this is the AGA group, where if Dopplers are abnormal or there are dropping centiles in the growth velocity, we call them FGR in AGA. So to tabulate the differences between FGR and SGA, we need to exclude primary defect or structural defect in the baby. FGR has poor perinatal outcome, SGAs have good outcome. FGR have Doppler signs of adaptation because of placental insufficiency. SGA have no Doppler adaptation because there is no placental insufficiency. We deliver around 37 to 38 weeks in case of FGR, while SGA, we prolong the pregnancy up to term, that is 40 weeks. So what is early onset and late onset FGR? The definition by Delphi. Early onset commences before 32 weeks, late onset after 32 weeks. And this is an arbitrary cutoff because there is a lot of overlap between the two. Coming to early onset FGR, here the placental damage is more than 30%. And placenta, we know, has two compartments: maternal compartment supplied by the umbilical artery and fetal compartment supplied by the umbilical artery. Maternal compartment by uterine, fetal compartment by umbilical artery. And there are villi floating in the maternal blood coming from the fetal compartment, wherein exchange of nutrition and oxygen between the mother and the baby takes place. So maternal compartment supplied by uterine artery, fetal compartment by umbilical artery. And therefore these two vessels which have a common destination, which is placenta, these two vessels are placental vessels because they tell us about placental compromise. Definition of early onset FGR by Delphi procedure. This is also the definition by ISWOG practice guidelines. So the solitary criteria are AC or estimated fetal weight less than 3 centile. So even if the AC is less than 3 centile and nothing else, no other finding, it is still FGR. Weight less than 3 centile, it is FGR. Another solitary finding is umbilical artery absent end diastolic flow, which, if present, alone is qualified as FGR. Contributory factors are needed when AC or estimated fetal weight is less than 10th centile but more than 3 centile. So here, either uterine artery BI more than 95 centile or umbilical artery BI more than 95th centile. Either of the two or both of the two, along with AC estimated fetal weight less than 10 centile, qualify for FGR. Now, late onset FGR, the placental damage is less than 30%. So, to differentiate early FGR and late FGR, early FGR is seen in 30% of the cases. Most of the cases are late FGRs. Early FGR, the problem is not with the diagnosis because these babies are very small because placental damage is high. It is more than 30%. So there are abnormal umbilical artery Dopplers and the diagnosis is easy. The babies are small as well. But the problem is with management because these babies are very small and it is difficult to ascertain the time of delivery, which is a challenge. Preeclampsia is seen in 50% of the cases. Hypoxia is more, but tolerance to hypoxia is good because the process is gradual and the baby adapts to hypoxia. Late onset FGR, the diagnosis is difficult because fetus is not necessarily small. Placental disease is low, it is less than 30%, and umbilical artery may be normal. Preeclampsia is associated in less than 10%. Hypoxia is not much, but the tolerance to hypoxia is poor. So you could compare early onset FGR with Sherpas who live in hypoxic condition for a very long time and get adapted. Whereas late onset FGR could be compared with someone who is living in plains and goes to a very high altitude. So the tolerance to hypoxia is less and the patient suffers from high altitude sickness. So now that we know what is FGR and how to differentiate SG and FGRs, is there anything to predict FGR in the first trimester? So we have a Samrakshan protocol, screening for preeclampsia and FGR, a 5-step approach in the first trimester between 10 weeks, between 11 weeks and 13 weeks and 6 days. Step 1 is taking the maternal history. Step 2 is taking mean arterial pressure. Step 3 is uterine artery PI. And step 4 is calculating the patient-specific risk for preeclampsia and FGR by putting all the 3 values in FMF calculator at the FMF website. And we calculate the risk. If the risk is more than 1 in 150, we advise tablet equaspirin 150 milligram HS to these mothers right from the first trimester till 36 weeks. And the last step is filling online Samrakshan forms, and we will speak more about this in a while. So now that we know that we have something to predict fetal growth restriction in the first trimester, we need to manage these patients. And for management, we need to understand some key concepts. Number 1, the placenta is a unique organ. Number 2, there is cardiovascular adaptation and brainstem suppression in FGR. And number 3, hypoxic threshold versus lung maturity. Placenta, the unique organ. 2 factors responsible for fetal growth are nutrition and oxygenation. Placental dysfunction is associated with fetal smallness due to malnutrition. and fetal compromise from respiratory hypoxia. So it's interesting to know about the fetal nutritional demand and fetal respiratory demand. In early part of the pregnancy, before 32 and 34 weeks, there is exponentially high nutritional demand of the baby. And so if placenta is dysfunctional at this time, the babies become very small and there is cardiovascular adaptation and Dopplers become abnormal. At this time, there is very low respiratory demand of the baby. And so even if there is hypoxia, the baby adapts to it. And so a nutritional capacity of placenta is used for diagnosis of FGR. And in later half of the pregnancy, after 32, 34 weeks, the nutritional demand reaches a plateau. And these babies, therefore, are not small because they don't need much nutrition. So the size may be normal, but the respiratory demand is exponential after 34 weeks. And therefore, these babies suffer from hypoxia very readily. And we use respiratory capacity of placenta to time delivery. So in early onset FGR, the Dopplers will be abnormal. The delivery will be based on abnormal Dopplers. And late onset FGR, there'll be problem with the respiratory system of the baby. And so there will be abnormal CTG, abnormal fetal heart rate, biophysical score, NSTs, and that is the basis of delivery in late onset FGRs. Cardiovascular adaptation happens in early FGR. We know there is severe placental disease in early FGR, and therefore there's severe hypoxia. It is a perfusion defect. Umbilical artery has high resistance because it has to pump blood into the placenta against the diseased placenta. And heart must do more work because it has to pump blood into this umbilical artery, which has a high resistance. And therefore, heart eventually fails. The right heart fails before the left because the right heart cardiac output depends on the placental resistance, whereas left heart cardiac output depends on the head and neck vessels or the brachiocephalic vessels, and we will see it as we go by. And so as the right heart fails, the ductus vinosus becomes abnormal because ductus vinosus drains into right atrium. Talking of the brainstem, the immature brainstem in early onset FGR is resistant to hypoxia, and therefore CTG abnormality, fetal heart rate, they become abnormal very late after the Doppler abnormalities set in. In early onset, Doppler is the trigger for delivery. In late onset FGR, mature brainstem is highly susceptible to hypoxia. And we know cardiovascular and respiratory centers are present in brainstem, and therefore CTG, fetal heart rate, breathing, all these are affected early in case of late onset FGR. And they can be abnormal even before the Dopplers, and CTG, therefore, is the trigger for delivery in late onset. So in late onset FGR, the placental disease is mild and hypoxia is mild, and therefore umbilical artery is normal. Heart is happy and ductus vinosus is normal. The mature brainstem is more sensitive to hypoxia, and therefore brain is the issue in late onset FGR. Talking of hypoxic threshold and lung maturity. So the challenge in early onset FGR is to deliver the fetus not too late for the fear of hypoxia and acidosis to set in, and poor long-term outcomes due to intrauterine hypoxia. And also we do not want to deliver these patients very early because of the fear of prematurity and neonatal death due to poor lung maturity. So what are the tools to gauge FGR, to diagnose FGR and for surveillance of FGR? Growth velocity is important because growth is a process. We need to plot growth graphs for diagnosis and for follow-up. So if the patient comes to us with earlier ultrasound from some other places, we need to incorporate those values in our software so that we get a graph. And for one pregnancy, follow one kind of graph. As for Doppler signs, they are used for diagnosis as well as prognosis because they reflect placental disease and they also reflect fetal adaptation to hypoxia. And so every third trimester scan has to include a Doppler. And that is the growth velocity curve. So growth is size variation with time. So this point value is the size and this curve is the growth. Coming to Doppler indices used to diagnose and stage Fgr. Uterine artery, umbilical artery, we know these are the placental vessels and they tell us about uteroplacental impedance and placentofetal impedance respectively. Middle cerebral artery, ductus vinosus and aortic isthmus are fetal vessels because they tell us about the response to adversity. And then we have the Dopplers as diagnostic markers, and we have already seen what all Dopplers are used for diagnosis. So these are umbilical artery and uterine artery in the first in early onset FGR. And Doppler as prognostic markers, they are used to help to trigger preterm delivery before 37 weeks, which is actually required in early onset FGRs. So the markers for prognosis and delivery are umbilical artery, ductus vinosus, and aortic isthmus, and CTG is the safety net because we need to deliver for late decelerations. These Dopplers have been very extensively covered by Dr. Sandhya in last session. I'll just touch upon them briefly. So uterine artery Doppler is a screening tool. It has no role in surveillance. It should be seen in all the 3 trimesters and more than 95th centile is considered abnormal. And that is the high resistance in uterine artery. The notch is no longer taken into account. And that is the normal low resistance, which should be seen as pregnancy goes by. Umbilical artery is a diagnostic as well as a prognostic marker. PI more than 95 centile is used for diagnosis, and progression to absent or reverse end diastolic flow is used for prognosis. Umbilical artery precedes abnormalities in umbilical artery, precedes CTG changes. It fails to identify mild placental disease in early onset FGR, and therefore it may be normal in grade 1 FGR. It also fails to identify all forms of late onset FGR because placental damage here is less than 30%. And umbilical artery is influenced by maternal breathing, fetal movements, fetal breathing, and hiccups, and also Doppler settings. So here we can see that the spectrum is going in and out of the umbilical artery. This is because of maternal breathing, and this should be taken into account. There's nothing like intermittent absent end diastolic flow in umbilical artery. So if you see in some loop absent flow, some loop present, it does not happen in single turns. So you need to correct your technique. But there can always be a difference in resistance in loops of umbilical artery, and you must consider least resistance for your assessment. And we really need to differentiate between absent and reverse end diastolic flow. And for this, do not increase PRF or the filters because the reverse component will disappear as it has a very low velocity. So we should always reduce the gain to look at the reverse component. And why is it so important to differentiate absent and reverse end diastolic flow? Because absent end diastolic flow represents 60% placental damage, reverse represents 70%, and absent represents severe hypoxia, reverse is suspicion of acidosis, Absent and diastolic, we will like to deliver after 32 weeks because it is hypoxia. And reverse flow, we will like to deliver before 32 weeks because it is acidosis setting in. And this is 30-70 concept. So high resistance umbilical artery flow happens because of 30% villus damage. Absent and diastolic flow, 60% villus damage, and 70% villus damage will result in reverse flow in the umbilical artery. And that is the cascade of umbilical artery from normal flow to high resistance to absent to reverse flow, and reverse flow also represents cardiac dysfunction. And this is to say that counseling is important in cases of very early IUGR regarding the prognosis of these patients, because if umbilical artery abnormality sets in before 26 weeks, these patients will have to deliver before 30 weeks because before 30 weeks, the abnormality will progress to severe Doppler abnormality. And it is seen that if umbilical arteries starts becoming abnormal before 29 weeks, they become severely abnormal before 33 weeks. And if it starts at 31 weeks, it goes on till 35 weeks when severe abnormality sets in and delivery has to be done. So roughly 4 weeks gap between starting of the abnormality in umbilical artery and progression to severe abnormality requiring delivery. And this counseling should be done with the patient if the patient comes with very early IUGR before 26 weeks. This paper in fetal diagnosis and therapy states that absent or reverse diastolic flow in umbilical artery, we have very little time with us, just 1 week prior to a terminal event. And therefore, if it is 30 weeks which has been achieved, the patient should be delivered. And then we should also be looking at the trend of the rising PI or the falling PI. So here we see that the umbilical artery PI is all over the place, but the general trend is upwards, and will worry for this patient more than this patient where the umbilical artery PI is falling. Coming to middle cerebral artery, it is a surrogate of hypoxia, and we ask, what is the baby hypoxic? It has value in late onset FGR, where umbilical artery may be normal. An MCA PI below 5th centile represents cerebral hypoxia. It represents brain sparing effect, which happens as a protective mechanism when fetus tries to supply more blood to the vital organs, the brain, heart, and the adrenals. Now, utility of MCA in early onset. Early onset FGR, we have severe placental disease and severely abnormal umbilical arteries. MCA will always be compensated, but it has no clinical utility. Delivery will happen entirely on ductus vinosus flow or severe umbilical artery flow. MCA is not used for surveillance in either early or late onset FGR. In late onset, CPR is used for surveillance. So that is the normal umbilical artery, and that is the cascade resulting in vasodilatation in the MCA in case of hypoxia. And this is paradoxically high resistance in MCA, which happens when the fetus has deteriorated to the level that there is cerebral edema which has set in. And we do not want our babies to go to this extent. We want to deliver them here. So MCA waveform is influenced by breathing of the baby, hiccups, and probe pressure. These cause increase in intracranial pressure and high resistance or reversal in MCA. And so they could be falsely reassuring. Coming to cerebral placental ratio, the question here is again, is the baby hypoxic? This is a ratio of MCA-PI upon umbilical artery PI, and it is the most sensitive marker for fetal hypoxia. It may become abnormal even when individually PI of MCA and umbilical artery are normal. CPR less than 1 is the earliest sign of hypoxia, and it is very sensitive marker for late onset FGR. A falling abnormal CPR less than 5 centile in late onset FGR is an indication for delivery. Coming to aortic isthmus, and this is an interesting vessel because it lies between aortic arch and the pulmonary arch, and this is the area after the emergence of left subclavian artery, and where the ductus arteriosus joins the descending aorta. Now, in systole, the left ventricle, which carries oxygenated blood, carries forward flow in the aortic isthmus, and in systole, the right ventricle, which carries deoxygenated blood, carries blood in the retrograde direction in the aortic isthmus. But the net flow in systole is forward flow. In diastole, the flow in isthmus is dependent on the resistance of placenta, that is the peripheral resistance, and the resistance of the brachiocephalic vessels, the head and neck vessels. So in normal pregnancy, the placenta has a low resistance, and therefore the flow is antegrade downwards in the aortic isthmus, whereas in IUGR, where the placental resistance increases and the MCA resistance decreases, the flow in aortic isthmus reverses. So in systole, there are two opposing forces, the left ventricular cardiac output, right ventricular cardiac output, and in diastole, it is peripheral resistance of placenta and brachiocephalic vessels, which are opposing forces on aortic isthmus, which is a watershed area, a meeting point of 4 variables. And this is where we can interrogate aortic isthmus in sagittal view and in axial view. And the waveform we can explain by the upward flow because of the forward flow of left ventricular output, and the downward flow by the right ventricular output in the reverse direction in aortic isthmus. And then there is a small end systolic reversal which happens after 25 weeks because of right ventricular right ventricle preponderance in later part of the pregnancy. We see this reverse flow as right ventricle pushes blood in reverse direction in aortic isthmus. In diastole, the flow should always be in the forward direction if the placental resistance is low, as what we see in a normal pregnancy. So what happens in IUGR? There is retrograde flow in the aortic isthmus because the baby tries to maintain oxygenation of the brain. Now, we know that it is the right ventricle which causes reversal of flow in the aortic isthmus, and right ventricle carries deoxygenated blood. So actually, it is the deoxygenated blood which is going to the brain when aortic isthmus reversal is taking place. And so these babies will have poor neurological outcome. And that is the cascade of flow in the aortic isthmus from normal forward diastolic flow to reversal of flow. So reversal of flow in aortic isthmus is a marker of poor neurological outcome in an FGR fetus, and reversal precedes ductus vinosus abnormality by 1 week. And there are some pitfalls as far as aortic isthmus is concerned. Net reversal only happens after severe umbilical artery abnormality, and aortic isthmus is highly specific but not sensitive. Normal aortic isthmus flow is reassuring, but abnormal flow does not always predict cerebral damage because there are multiple players acting on this watershed areas, and it is difficult to predict which one is the culprit. So aortic isthmus is actually awaiting stronger evidence because before we put it into a regular use. Coming to ductus vinosus, this is a trumpet-shaped vessel which carries oxygenated blood from umbilical vein to the right heart through the foramen vein to the left heart. And this trumpet-shaped vessel is narrowest at the junction with the umbilical vein, and this is where we see the dialyzing and we measure the velocities. Now, we know that right ventricular cardiac output depends on the placental resistance, and left ventricular cardiac output depends on brachiocephalic resistance. So in FGR, the placental resistance increases, cerebral resistance drops. So right heart fails first, followed by the left heart. And so Dr. Bijoy's words, the ductus vinosus is the tragic hero. It supplies the left atrium. From the right atrium, blood goes to the left atrium through the foramen vein, and then it supplies blood to the heart and to the CNS by head and neck vessels, but it bears the brunt of right ventricular failure and at delivery perishes to an unseen death. And that is the waveform of ductus vinosus. The first peak is the ventricular systole, second peak is early ventricular diastole, and this is the atrial contraction, the A wave, which corresponds to atrial contraction. And when there is diastolic failure, there is increased ventricular end diastolic pressure and decreased ventricular compliance due to diastolic failure. And there is pulsatile ductus vinosus, wherein the A wave reduces or it may also reverse. This is also reflected in IVC, umbilical vein, and CTG. And that is the cascade of flow in ductus vinosus from normal flow to high resistance flow, and that is the reversal of A wave happening because of decreased cardiac compliance. Ductus vinosus is the strongest single Doppler parameter to predict the short-term risk of fetal death, especially in early onset FGRs. And a pulsatile ductus vinosus, we have very little time left with us, just 78 to 72 hours. And so we need to complete the steroids and deliver the baby irrespective of the gestational age if we have reversal of A wave in ductus vinosus. And so now that we know our vessels, we need to know the management protocol. And the challenge is to keep a balance between intrauterine hypoxic insult and premature delivery. The aim is to time the delivery electively with lung maturation, and for this we have stage-based management protocol by Barcelona, and we need to adopt this because we need to reduce clinical practice variation and we need to maintain uniformity so that we all are on the same page, we all speak the same language and understand each other's reports. Barcelona stage-based management is common for early and late onset FGR. It is a simple algorithmic approach, easy to follow, and there's an app available wherein you can put all your values of Dopplers and it will tell you when to screen next and when to deliver. We should also know that there is increased chances of survival without handicap by 2% per day before 28 weeks and by 1% per day up to 32 weeks of intrauterine life. So to say that we need the baby to be intrauterine as long as possible without hypoxia or acidosis setting in. And that is the cascade of events which happen in early onset FGR. So to begin with, because of the placental disease, there is increased uterine artery PI more than 95 centile and increased umbilical artery PI more than 95 centile. Before umbilical artery, we could have a CPR falling below 5th centile. And then we also have MCAPI less than 5th centile at the same time. So all of this is stage 1 FGR. And then there is hypoxia, further hypoxia setting in. Umbilical artery shows absent flow and aortic isthmus shows high resistance or reversal. And this is late hypoxia. And then we have early acidosis wherein umbilical artery shows reversal of flow. Ductus vinosus shows high resistance more than 95th centile. And then we have late acidosis or severe acidosis wherein there is a serious injury or death of the baby, wherein ductus vinosus shows a reversal of A wave and there is CTG abnormality, biophysical scoring abnormal, and CTG decelerations of the heart. So based on these events, we have stage-based classification and management of FGR. As for small for gestational age babies, these are weight less than 10 centile and the Dopplers are normal. So we need to look at them fortnightly, that is after 2 weeks. And we need to deliver them at around full term, that is 40 weeks. Stage 1 FGR is mild placental insufficiency, and the criteria are fetal weight less than 3 centile or any of these, uterine artery more than 95th centile, umbilical artery more than 95 centile, CPR less than 5 centile, and MCAPI less than 5 centile. And these babies in stage 1 FGR should be monitored weekly. So stage 1, monitor once a week. And if we have achieved 37 weeks, we should deliver them. We can also deliver them between 34 to 37 weeks to be more precise. Stage 2 FGR is severe placental insufficiency seen as absent flow in umbilical artery and reversal of flow in aortic isthmus. These babies have to be monitored twice a week. So stage 2 and twice a week. And if we have achieved 34 weeks, deliver them. They could also be delivered at 32 weeks, between 32 and 34 weeks by C-section. Stage 3 FGR is advanced fetal deterioration and early acidosis having set in. We have reversal of flow in umbilical artery and high resistance flow in ductus vinosus. And we need to monitor these babies every day or every second day. So almost 3 times a week, stage 3 and 3 times a week, we need to monitor these fetuses, and we should deliver them if we have achieved 30 weeks. In fact, it is between 28 and 32 weeks. So between 28 and 30 weeks, we would deliver for ductus vinosus abnormality. Between 30 and 32 weeks, we would deliver for reverse flow in umbilical artery. And stage 4 FGR is severe acidosis and high risk for fetal death. There is reversal of A wave in ductus vinosus. There's spontaneous heart rate decelerations, abnormal CTGs, and we have to monitor these babies maybe morning, evening, but we would prefer to deliver them if we have crossed 26 weeks. We would give steroids and do the section. To summarize the stages of cardiovascular adaptation in IUGR, stage 1 is weight less than 3 centile or CPR less than 5 centile, uterine artery PI more than 95 or MCAPI less than 5 centile. Umbilical artery may be normal in stage 1 or there could be high resistance in umbilical artery as well. And ductus vinosus is always normal in stage 1, and this is also the scenario that we see in late onset FGRs. Stage 2 Fgr is absent endosteric flow in umbilical artery with reversal of flow in aortic isthmus, and ductus venosus will always be normal in this case. Stage 3 is when acidosis has set in. Ductus venosus is more than 95 centile and reverse flow is seen in umbilical artery. And stage 4 is a reversal of A wave in ductus venosus with CTG abnormalities and heart rate decelerations. So stage 1 and 2 are hypoxia, early hypoxia and advanced hypoxia. Stage 2 and 3 are early acidosis and advanced acidosis. And then there's this magic figure of 32. 32 weeks is universally accepted as timeline beyond which we are not worried about lung maturity that much. So you deliver for hypoxia after 32 weeks. And before 32 weeks, we would only deliver if we have worse conditions inside, because we are worried that the baby could die outside the uterus because lung maturity is not achieved. So before 32 weeks, deliver only for a very severe abnormality, which is acidosis. So deliver stage 1 and 2 Fgr, which are hypoxia, after 32 weeks, and stage 3 and 4, which are acidosis, before 32 weeks. And like I said, between 28-30 weeks, deliver for ductus venosus abnormality, between 30 and 32 for reverse flow in umbilical artery. So the right time to deliver in early onset Fgr. We know early onset have a severe placental disease, umbilical artery will be abnormal, brain stem is resistant to hypoxia, CTG abnormality happens late, and ductus venosus abnormality will happen earlier, or sometimes these both can coincide, but we need to deliver for ductus venosus abnormality or severe abnormality in the umbilical artery. And this is all that I've spoken, a gist of all this. So SGA, the Dopplers are normal. In stage 1 Fgr, it is about abnormality in umbilical artery, NCA and uterines, and we watch them weekly and deliver them if it is 37 weeks. Stage 2, it is abnormality in the umbilical arteries and the aortic isthmus. We follow them thrice every 3 days, that is twice a week, and deliver if they are 34 weeks. Stage 3, the abnormality is in the umbilical artery and the ductus, and it is acidosis that is setting in, and we need to follow them thrice a week and deliver them if they have reached 30 weeks. Stage 4 is abnormality in the ductus venosus and umbilical vein, and we need to deliver them stat. So to conclude, early onset Fgr, the heart bears the brunt because immature brainstem is resistant to hypoxia. So listen to the heart and listen to the Dopplers. In late onset Fgr, the heart is happy, brain bears the brunt because mature brainstem is sensitive to hypoxia. And so listen to the brain, look at CTG abnormalities to deliver. And before closure, I would like to present a couple of slides on samrakshan. Why do we need samrakshan? The argument may be we already have evidence in the form of FMF protocols, so why reinvent the wheel? Well, samrakshan is centered on the Indian women and it has local relevance. So if we see the numbers for annual childbirth, they are 300 lakh in India and 6.8 lakh in UK. Preeclampsia incidence 8 to 10% in India and 2.4% in UK. Putting this into numbers, India has 24 lakh preeclampsias a year, and UK has 0.16 lakh preeclampsias a year. 24 lakh versus 0.16 lakh. And we are following the FMF protocols for preeclampsia screening, which comes from UK. And that is why we need Samrakshan. We need our own protocols. We need our own guidelines. We need our own cutoffs. And for that, we need all of you to fill forms and submit to Samrakshan so that we have the data. What we already know is that 8 to 10% of pregnant women in India develop preeclampsia and 20 to 35% fetuses may be growth restricted. And Samrakshan found that nearly 1 in 5 women in the first trimester may need low-dose aspirin 150 milligram HS based on the cutoff of 1 in 150. Samrakshan has screened almost 14,000 women and the results are such. So between 2019 and 2022, the preeclampsia risk has fallen to 1/3, FGR risk fallen to 1/3, preterm birth fallen to half. Between 2016 and 2022, the impact on neonatal mortality is that it has reduced to 1/3, perinatal mortality reduced to half, and maternal mortality is reduced to half. FGRs reduced to 1/3 and 22 lakh FGR babies reclassified as SGAs and so delivered normally at term. So we could abate so many of preterm babies. Stage 1 FGR babies delivered at term, this figure improved from 57 to 75%. So we could carry on the stage 1 FGR to term, and this is because of integration of Dopplers in our third trimesters. And there is a thought. So how the Indian scenario of perinatal mortality will change if we start doing preeclampsia and FGR screening, if all of us start doing it. Total pregnancies in India is 30 million. Out of this, approximately 8% are at risk of preeclampsia. That makes it 24 lakhs. If preeclampsia screening is done in all pregnant ladies, we will detect 20 lakh of these high-risk pregnancies, and when we give them aspirin, they will benefit in 80% of these, and that is the figure we know that aspirin is effective in reducing 80% of preeclampsias. So this comes out to be 16 lakh. So we are benefiting 16 lakhs mothers and the same number of babies if we all start doing preeclampsia and FGR screening in the first trimester by Samrakshan protocol. I feel for the cause. Do you? I have joined the mission Samrakshan. Will you? Because two voices are louder than one. And then, kuch hai yahan, junoon sa. Thank you very much.
Thank you, Dr. Kavita, for that wonderful presentation. This was an amazing presentation. You covered various aspects of early fetal growth restriction. And thank you once again for that presentation. Before we move on to the next session, let me invite one of our chief guests who couldn't join in the initial part, Dr. Praveen Jiu, the Secretary of Karnataka IRIA, is with us. Dr. Praveen?
Yeah, thank you, Dr. Richo.
Yeah.
Really, it is great to be, more than chief guest, I think it is great to be an audience for this great lecture by Dr. Kavita. Because I think in future, whatever that pre-eclampsia is there, it will become preventive eclampsia with all this preventive radiology. That is what the main aim is, I think. That is what Dr. Kavita in the end, when she told that I am for Samrakshan. I think this is a great move, and one most important thing I would like to tell all our radiologists is we should be patient, because those who come for this scanning for us, they are not patients. It is pregnancy is a physiological phenomena. We never should think that they are patients. It is a physiology. Getting a gestational diabetes is a physiology. In some, gestational hypertension is also a physiology. Only thing is we need to assure them that it is not a very bad thing to have, which is curable if detected early. That is what the main aim of samrakshan is: prevent the maternal and the fetal mortality. I think in future, maybe with preventive radiology in collaboration with other departments, they would be able to prevent even eclampsia. I really don't know, because the future we never know and anything can happen. I really congratulate Dr. Rijo, the whole team of Kerala, Dr. Gomati, and all the speakers, and my co-chief guest, Dr. Shibani. Really, thank you for this great opportunity given to me to attend. More than being a chief guest, I'm happy to attend this great lecture by Dr. Kavita. Thank you, sir.
Thank you, Dr. Praveen, the young and dynamic Secretary of Karnataka. Karnataka has recently organized a webinar along with IMA State Branch of Karnataka and the IRIA Karnataka State Chapter and the IRIA Bellary Subchapter, in which the State Health Ministry health officials has assured that they will seriously consider the Samrakshan protocols all over Karnataka, because Karnataka has got amongst the southern states, Karnataka's maternal mortality is slightly on the higher side. And that is why, especially in the rural Karnataka. So they have taken this project seriously, and we got assurances in those meetings that they are going to take it to the taluka level, 78 to 8 taluka levels in Karnataka. And thank you, Dr. Praveen, for the wonderful efforts that you are taking to promote Samrakshan in Karnataka. Once
Thank you, sir.
again,
Thank you, sir. Thank you very much.
I wish to thank the Delhi President, Dr. Shivani Mehra, also for joining us. And Dr. Sandhya, can we move on to the next part of our session?
Have few cases to discuss. So I think, Kavita, will you present your case, or I start with the cases first?
As you say, you can go ahead with your case, Sandhya.
Okay. So I'll share my screen. Is my screen visible, sir?
Yes.
Enable editing and go to the slideshow mode, please.
So, Dr. Kavita, wonderful presentation. I think most of the doubts of all the audience and everyone should have been cleared. But I think with the case-based discussion, it will make more clear. So I have two cases to present here. One is a 32-year-old second gravida with previous live pregnancy. The viability scan was done. Am I
The
audible?
slide is not moving, Sandhya. Are you moving the slides?
So, is the case seen? Case one?
We can only see
No.
the
Sandhya,
first
can you
slide.
enable editing first and then move on to the slideshow mode?
Enable editing. I'm
Yeah,
not doing any editing.
it's not.
This one.
Okay, share the screen once again.
Case-based discussion.
You have to yet do the enable editing. Yeah.
Screen has stopped. Window is closed. Just a
There are too many antivirus. Start the screen. Most features are disabled because your office put is in. Can you activate and or go to the slideshow mode on the bottom part of the screen? Yeah. Okay. It's fine. It's fine.
Is it running now? Can you see
Yeah.
case 1?
Yeah. Case 1.
Yeah.
Yeah.
32-year-old, second
Yeah.
gravida with previous live pregnancy. Viability scan was done at 7 weeks, which shows that the single live intrauterine fetus of 6 weeks 5 days maturity, which was corresponding to the dates. So here I would like to mention that always dating of the pregnancy is an important aspect to label in future any pregnancy for FGR. So you must check with the previous scans from, even if they are from the outside center, you must check them and see if the dating of the pregnancy was done accurately. And once you date the pregnancy, you never change it. So the NT scan was done at 12 weeks, which shows a high PI in the uterine artery, which was more than 95th percentile, and rest everything was normal. And there was a previous history of preeclampsia in the last pregnancy, but the outcome was normal. This is the level 2 NT scan, which was done at 12 weeks with the CRL of 54.9 centimeter, 5.49 centimeter, and the NT was normal 1.1. The right uterine artery PI was 1.5 and the left was 1.3. So the mean PI was more. So my question to you is, what should be done next? We have a patient with high mean uterine PI, which is higher, and rest of the parameters are normal. What you will do next? Dr. Kavita, would you like to answer?
Yeah, we'll do the preeclampsia and FGR screening.
Yeah, because we are
Uh,
all following the Samrakshan protocol.
Samrakshan protocol. Yeah.
Yes, so the calculate the risk for preeclampsia and FGR in pregnancy by using Samrakshan protocol, which we all are doing, I think. And this was the form filled for this patient, which shows the calculated risk for preeclampsia for history and from all the parameters, that is mean arterial pressure, uterine artery PI is 1 is to 57 for less than 37 week, which is a high risk because what we use in Samrakshan is a cutoff of 1 is to 150, and we have advised the patient to take aspirin at bedtime, which is recommended. So this patient started with the low dose aspirin, and would you like to do any other test for this patient along with this? I think dual marker should have been done, and because if in dual test, if you see a low PAPE, which is also a sign of early FGR, we usually recommend along with the NT scan to go for a dual test, but it is important that low PAPE is also a sign of early FGR. We also have to look into the moms whenever we see a dual test.
We could add on PLGF. Yeah.
Yeah,
PLGF.
so PLGF can be added if the patient is affording, because it adds to the sensitivity of risk calculation for early FGR and preeclampsia. So this patient went back and came back at 19 weeks for the target or the anomaly scan, which came out to be normal, except that the uterine arteries were still on the higher side. So this was the scan. As you can see here, all the fetal parameters are showing normal percentiles, including the EFW, that is the fetal weight, which was at around say 37 percentile, and rest everything was normal. This patient came back to us at around say 26 weeks 4 days for a routine growth scan, and which showed that the fetal weight was at fifth of the percentile, AC was at fifth of the percentile, and the uterine arteries were still on the higher side with at 97th percentile and 96th percentile. So is it fulfilling the criteria for early FGR? Do you
Yes.
think? Yeah.
This is stage 1, early onset FGR.
Although the guideline says that the early FGR is less than third percentile, but if you have any of the contributory factors which you have already discussed in your presentation, that if the uterine PI is more than 95th percentile, it is a contributory factor along with the uh, um, uh, fetal weight ranging from 5 to 10 percentile. So that it labels this patient for early FGR grade stage 1, right?
What was the blood pressure of the patient?
Blood pressure was, she was already on medicine, so it was normal, and rest of the parameters were normal. There was no other abnormalities as such.
So she was a hypertensive
Yeah, she was hypertensive on
before
medicine.
pregnancy.
Yeah.
Okay.
So, as we have told, we have taken the solitary as well as the contributory criteria for early onset FGR. So, we called this patient after 1 week for the Dopplers. Only the Dopplers were done, which was normal, except mean uterine artery, high resistance PI. At 28 weeks, we have done the growth scan for this patient, which shows that the all the parameters now are at the fifth percentile almost, with the umbilical artery showing high PI of 99 percentile, and MCA and CPR were normal, but CPR was at 6th percentile. These are the growth graphs for this patient, which shows that there is a lag there. The FL as well as the weight is at the 5th percentile, or even weight was less than 5th percentile, and umbilical artery was at a is at 97th percentile. So at this time, what advice will you give? How do you follow these patients now?
So this is still stage 1
Yeah,
FGR, and we will follow her up once a week. We'll
once.
call her after 1 week.
So after 1 week, she was called back at 29 weeks 4 days, and this is the umbilical artery showing absent diastolic flow, and ductus vinosus was normal. Fetal activity was good. NST was normal. So with absent umbilical artery, this has become now stage 2.
It's stage 2 FGR.
Huh?
Yeah.
So for
Yes,
stage 2, you need to follow her up twice weekly,
twice a week.
and still we can go ahead with the pregnancy. So because it is still ductus was normal, so in the patient was advised to get admitted. There was steroid given because you know how unpredictable the early FGR. We need to know to balance between the prematurity and the FGR, when to deliver, when to intervene. So precautionary steroid was given. Neonatologist consultation was done so that the parents are counseled about the outcome, and at that time daily Dopplers were done. So at 30 weeks, there was reversal of flow, diastolic flow in the umbilical artery, and the ductus venosus shows high resistance flow, although it was not a reversal of the A wave. Again, at this time, we decided to take out the baby because it was already there was reversal in the umbilical artery. So it was delivered by the cesarean section, and the baby weight was 98 grams. The baby stayed for 1 month in the NICU and survived and discharged. Now, after 1 year, there is normal development in this patient. So, what we gather from these kind of cases is that the correct dating of pregnancy is important. Check for the contributory factors to diagnose early FGR, and surveillance according to stage of the FGR is important. We need to have a multidisciplinary approach to involve and guide the parents about the outcome, about the NICU stay, about the cesarean section if needed. So we have to counsel these patients proper way, because sudden IUDs are also there in these patients. So always decide according to the facilities available in your area, because NICU facilities and emergency LSCS can also be the hour of the need at that time. So uh, anyone has any comments to add on to this? It will be beneficial
Yes,
for all the
Sandhya, I just want
audiences.
to excellent case, and you have covered most of the salient points. But as part of the Samrikshan, what we have seen from various parts of the country is actually we don't have much of a data that is coming out on the early FGRs in India, especially from tier 2 cities and below that.
Mhm.
So the consensus, the Delphi consensus, everybody talks about, and if we follow, even in the Delphi consensus, the experts were asked, what is the arbitrary cutoff that should be taken to decide which is early FGR and which is late onset FGR? And majority agreed for 32 weeks. As another, the next category that agreed was 34 weeks. But their questions were whether it is below 28 weeks or between 28 and 32 or 32 or 34. So it's a consensus of some experts, especially 40 out of the 56 experts came from the Europe and America, Western world, with tertiary centers with a very low incidence of FGR and preeclampsia in those countries. So what we need to understand, especially with the Samrikshan experience that I feel, and from the different levels of healthcare, early FGR is quite common in India, especially in the central belts of India, and it is not being. That's why, and the incidence of preeclampsia is also quite high. When we say 8 to 10%, that's just an average that we are taking as a national average. Some places in India, it is nearly 25%. What we need to understand is we have to get the data and understand this and have our own guidelines for India for better outcomes. Why we have in Samrikshan protocol, we have introduced two basic categories: preeclampsia screening and FGR screening, and FGR staging with Dopplers at second and third trimesters, so that we can facilitate better, so that we can. And what one particular category that we are still not included or considered is India is a country which has a lot of malnutrition in amongst mothers, anemia amongst mothers. So many of these mothers, and even constitutionally small constitutionally small mothers are also there. For which, if you look at the FMF calculators and all, the cutoff, Lalit sir, what is the cutoff that? What is the height? You have got so many patients who are very short.
Even the there so many patients are of small height, and even the fever, the malaria is causing grade 3 and grade 4 FGR cases and early FGR also, and fever is very common. Yesterday, which I discussed with you all, that is having fever since last 2 to 3 months. So fever is also the one of the important cause.
Yes. So malnutrition,
And
anemia,
yes,
infections, maternal diseases complicating FGR is something that we have not yet included in all these guidelines and this thing, because they are not aware of it.
yes.
This is problems that is specific to India, which our data, we have to collect that data and then incorporate and come out with the guidelines. So my point is, maybe in India, we may have to look very early FGRs, maybe before 24 weeks, or between 26 and 32 weeks, there is a category, there is a subcategory that needs special considerations, that may be having a maternal predisposing factor in terms of malnutrition, anemia, and infections and all those stuff contribute, and even the maternal constitution also contributing to the early FGRs, which eventually will lead to a lot of preterm births in India.
Rejo,
Yes.
in our Guna 1800 patient, I got 50 early FGR cases
Okay.
and 148 late FGR. So,
Right.
if we start from T5 scan properly, means we have to identify the early FGR cases, we can get so more cases in our subduction protocol.
Right. Right. So biometry and Dopplers has to be integrated. Maybe in India, we may have to assess the maternal characteristics also for early possible early detection. And again, the biochemical characters factors like PLGF and all are showing, and the soluble, there are new markers also have come in, maybe of use. We have to explore all the possibilities, because we have got a problem which doesn't fit into the existing guidelines or classifications, because those experts are not aware of our conditions that exist in many parts of India or many parts of the developing world. So this is the comment I want to make. Maybe Samrakshan, with a lot of data coming from all the places, we will be in a position to further explore and understand this, and maybe at some point of time in the future, we may have some guidelines and better management guidelines for better outcomes in terms of to avoid preeclampsia, fetal growth restriction by continuous monitoring and applying these protocols. So that our perinatal mortality and maternal mortality will be significantly reduced.
Exactly. We see so many cases, but I guess they just become numbers, and we do not really apply our mind to the fact that we need to do something to prevent it. It's just that the sheer numbers that turn up in our kind of institutes, we just we don't really now it's an eye opener for us as well, that we can contribute so much by adding to the statistics, and really looking out for the cutoff values, and maybe do a project on this as well, because
Yeah.
that's
That's very encouraging. And in the Samrakshan group, we had a case, our discussion. I noted a point that the 1 in 150 cutoff that we take for preeclampsia, and it's the same cutoff if we are taking for FGR, but the incidence of FGR is much more higher in India. So is that cutoff right? We need to reconsider that cutoff, especially for India, because I don't know that this is something that we need.
Rejo, I got 6 patient which were not in the first trimester. They were above the 180 for FGR and as well as for the preeclampsia, but they become in the second trimester they were high risk and they
Yeah.
developed P. So
Yeah,
this is also one of the.
Yes, sir, we have to prove this with data and say that otherwise these cutoffs, we tried it with 1 in 50 cutoff, 1 in 100 cutoff, and 1 in 50, but we have not tried with cutoffs more than that. And how much of false positive and how false negatives can come, something that has to be
I got
collected.
6 cases among this 1800 cases.
Sir, maybe we have to keep one as an intermediate risk also. As we keep a cutoff of 150 as higher risk, maybe from 150 to 300, we have to keep at intermediate risk and follow them also at a certain point.
Yeah,
as we have cutoffs from
we may have to work on that. Maybe may not be 150 to 300. That will
yeah,
include a lot
maybe
of
it's
false.
just a thought. Yeah.
Must be a narrower range, I feel. But
Yes.
this is one area we need to work, especially in India, looking into our statistics and the kind of incidents that we have here.
I have one more case if the time permits.
I think it is already 10:25.
Yeah.
My it's we in the south sleep early. So
No
I think
problem.
we will take it up in our next sessions, and
Okay.
I think we had a very good session with Dr. Kavita giving a very detailed description on early FGR and Sandhya showing a very interesting case. And Sandhya, I hope you don't mind. You
No, sir, not at all.
okay? It's 10:35 now. I think it is time to wind up the show today.
Yeah.
And tomorrow it's the final session of this series, or as part of the preeclampsia week webinar series. Tomorrow, Dr. Neelam Jain will be talking to us on late onset FGR and FGR in AGA fetuses. And Dr. Bavaharan and Dr. Lilith will be joining tomorrow for the discussion. And that will be the final session that we will be having in this series. We had several state presidents and secretaries. Tomorrow's chief guests are the president and secretary of Rajasthan State Chapter, Dr. Subhash Taylor and Dr. Jivraj Singh. We are honored to have Dr. Jivraj Singh attending today's session. Thank you, Dr. Jivraj, for joining today. And before we wind up, I would like to thank the chief guest once again, Dr. Shibani Mehra, President of the Delhi State Chapter, one of the most vibrant and dynamic state chapters of IRIA in the country, and also to Dr. Praveen Giu, the Secretary of Karnataka State Chapter, which recently conducted the national conference at Bangalore. The speakers today, Dr. Kavita Aneja, for the wonderful talk. Thank you once again. And
Thank you.
Thank you,
host.
Dr. Vijay. Thank you so much. It has been
Thank you.
wonderful and an eye opener. And you were not there when I was saying earlier that I'm going to be doing all that I can in my capacity as a teacher in a medical college, as well as leading the Delhi chapter, to contribute as much as I can to this Samrakshan, because this is the best way to actually give back to the society. This is indeed our best contribution. And I really, I actually applaud you for having um, carried it forward so wonderfully.
Thank you.
Thank
Thank you,
you.
Dr. Shivani. That is a very heartwarming reassurance that has come from Delhi State Chapter, because national capital is with us is something that
Yes.
we
Of
all
course,
look forward.
of
Yeah.
course, of course.
And before we wind up, I would also like to thank Dr. Sandhya Tankar for anchoring the show today,
Thank you.
because I had a
It's a
cardiovascular webinar.
pleasure to be there.
Yeah.
Thank you
And
so
Dr.
much.
Lalit sir being the panelist, and the MedPiper team, Dr. Ms. Soumya and Trivedi Rupnath, for all the technical